Well, why don't we get started? My name is Dr. Tony DeJoy, and on behalf of myself and Dr. O'Connor, we'd like to welcome you to this session. This is also being broadcast remotely, so we welcome those of you that are online as well. And as a reminder, there will be a way to field questions during our question and answer period from the online watchers as well. So the title of this is Rectifying Bone and Joint Health Disparities to Help Women and Minorities Thrive. Maybe the first question we have is, why are two orthopedic surgeons running the session? But you'll, I think, see there are good reasons for it, and certainly with Mary's leadership, it's been, she's really led the way among orthopedists to focus on wellness and health and prevention, not just the treatments and the surgery side too. So with that, a couple of things that I think Mary and I talked about that are important is this is the first time, for instance, that this kind of session has been held at the Magee Summit. Bone and joint health may not always be at the top of the list of problems, and certainly maybe not even with women that have bone and joint problems. But we first would like everyone to realize it is a problem. It's a high impact problem, very prevalent problem. Secondly, that there are disparities in care, and not just gender disparities, but there are other disparities, and Mary will talk about that we need to address. And the third part is that in many ways our system of care delivery has led us on this pathway, and we'll talk about why when we do that. And lastly, and most importantly, is I think both Mary and I are really how to solve problems, and not just talk about the problems, but to give you tools, methodologies, approaches that can solve some of these problems, not just in the overall care, but also the disparities. So those are the sort of the goals. Today, I'll give a brief introduction. Mary will talk in more depth, and I'll come back up to talk a little bit to introduce what will happen tomorrow. So we'd also like to plant the seed. We are going to have a how-to workshop, 2-hour workshop tomorrow. So if you're interested in the themes and what we're doing, tomorrow's really focused on giving you the tools to go back home and start providing solutions yourself. And it's not just for bone and joint health. The tools that you will hear about and the methodologies and approaches are for any care experience in any setting to reduce disparities and provide ideal care. So we hope that if you'd like to attend tomorrow, think of it as, yes, we use bone and joint health as an example of what you can do, but the lessons and the tools you can apply to your own care experiences as well. So just as a higher level review, again, high impact, very prevalent. It's nationally, 1 in 2 adults are affected in some ways. This is twice the rate of chronic heart and lung disease, and women are disproportionately affected more than men, as well as subgroups within that as far as racial factors, socioeconomic factors. Everyone is living longer and more active and wants to stay active. There's no doubt about that, particularly with the baby boomers. It's in all of our offices, everyone wants to stay active. And then lastly, and this addresses some of the systemic problems, is musculoskeletal issues are sort of like a cluster of orphan diseases in the sense that there's no one provider that owns the bone, right? And you think about it, we deal in one phase, rheumatologists do another, OBGYN may do another, endocrinology another, but there's no sort of central approach to that. And that creates these silos in healthcare, which then result in uncoordinated and fragmented care. And there's no doubt that happens in bone and joint health. Why hasn't it been sort of a higher impact kind of issue? Well, first, I think the lack of education and understanding by patients, but also by the providers, because many PCPs, for instance, don't even appreciate some of the factors that we'll be talking about. It does have low mortality. It's not like cancer treatments and heart disease and things that have a very high mortality. It's not zero, though, because especially if any of you've had family members fall and break their hip, right? I mean, there's a high mortality associated with those kinds of things. But it definitely fits in differently. But it is high morbidity. It affects people's activities. As far as the impact on the economic system, it's huge. And most importantly, it can result in chronic pain. And chronic pain syndromes, we know, are difficult to deal with. So why does it matter? It's widespread, high impact, high cost. Depending on the surveys you see, I think musculoskeletal problems for Medicare is usually number 1 or 2, if you can include back and all expenditures for Medicare. So it's very high impact for the community, not just as individual patients. It's not just a disease of older populations. Many of the things we'll talk about start in your youth, and are preventable if you do have early evaluations or early education. And there's no doubt there's disparities for care on the patient side, but also on the provider side. And we have to solve the provider side to help solve the disparity that occurs with patient care. So we all have a role in playing improving bone and joint health. And that brings me to Mary. I've known Mary for quite a few years. One of the things I always talk about is we sort of both started in the technology realm with navigation and robotics, right? And all that, but we also, both of us, I think, made a flip to recognize that technology is important, but process with technology is probably more important, and process by itself is probably even more important as far as having a high impact. And you'll hear more about that from Mary. But she's a nationally recognized leader for health equality. She is an orthopedic surgeon, but she also chairs an effort that you'll hear about called Movement is Life, which they just had their caucus last week in DC. She's been a real champion for that since 2010. She's always championed diversity and inclusion in the orthopedic side, on the provider side, not just on the patient side. And she actually was the past chair of the AAOS, American Academy of Orthopedic Surgery's Diversity Advisory Board, and on Women's Health Issues Advisory Board. She's been practicing for Mayo Clinic. She's started the program led the program in Jackson, then Yale. Recently, she is now CMO for a startup company, which I hope we'll hear about in this, because it's quite a transition for a practicing orthopedic surgeon, but no less has kept her passion for addressing the issues that are here. So I'd like to introduce Mary. She's a real champion, and on top of it, she's a Pittsburgher. She grew up in Newcastle.
It's always hard to sit and listen to someone introduce you, I think. I'm delighted to be here with you, very honored that Dr. DeGioia invited me, and want to share with you some thoughts. Can we get my slides loaded? Tom? There we go. Okay, there we go, I got it now. Okay. So I thought we'd talk about the O conditions and women's health. A couple disclosures: I do consulting work for Zimmer Biomet on health disparities, and I'm also a consultant to a Swedish company called Bone Support. Now, I'm speaking to a sophisticated audience, but I'm just going to have a couple premises that we're going to all agree on. First, women are not little men. Little women are also not little men. But it doesn't always work that way, particularly in research where it's incredulous that we see studies published where sex, gender are not even identified in the methodology, let alone race, ethnicity. The second is that all women are not the same. So we know that there are racial and ethnic differences in conditions which can be multifactorial. Are there going to be underlying epigenetic factors that contribute to these differences? I think probably. I don't know that we have data on that, but I was just thinking about it because I was listening to the finalist presentations for the Magee Prize. They're excellent, excellent talks. So the first condition to talk about is well known: osteoporosis. Okay. Most medical providers, PCPs, internal medicine physicians understand that osteoporosis is a significant health issue for women. They also appreciate that it's essentially a silent disease. And most women don't pay attention to this until they sustain a fracture. Now, this is not a disease that is just about women, because it happens to men too. It just happens to men about 10 years later. And interestingly, this was like the only condition that I could find where I found reverse discrimination in the clinical trial and medical literature. Because almost all the big pharma studies on bisphosphonates were all done on women. Like, as if men don't get osteoporosis? Of course men do. Now, again, that's a very unusual situation, right? Because if you look at clinical trials for all kinds of other commonly used medications, they're dominated by men. And in fact, if you look and see the drugs that are most frequently pulled off the market, they're pulled off the market because of adverse effects in women. But nonetheless, for osteoporosis, the women have been well studied and the men have had very small studies, 200 subjects, where the studies with women are 20,000 subjects. So it's a silent disease. We don't pay enough attention to it. And of course, the key is prevention of osteoporosis. So over the age of 50, it's estimated that 50% of women and 20% of men will suffer an osteoporosis-related fracture. That's honestly like mind-boggling if you think about it. And the cost to the healthcare system, and as Tony mentioned earlier, the suffering of patients related to these fractures is not inconsequential, okay? And so the fact that we do not pay more attention to this highlights the failure, in my opinion, of our healthcare system to really provide good care to everyone. So this is a greater impact to women than men, but it's still really important. Now, let's look at the influence of race and ethnicity. So over the age of 50, estimated percent to have osteoporosis for non-Hispanic, white, and Asian women, almost 16%. For African American women, that's about half at 7.7. Hispanic, even higher, 20.4. Now, I mean, there are going to be reasons why we see this difference, and certainly we know there's some genetic predispositions, right, for some people to develop osteoporosis, but we still need to pay more attention to these race and ethnic differences in terms of how we're approaching population health. Because, for example, I don't believe that in the Latina community, the importance of bone health is emphasized. And since they are the cohort with the highest risk, that's certainly something we can improve on. Now, we all know it's about prevention, diet, exercise, healthy lifestyle. You know, if I had a magic wand, what would I do? I would erase childhood obesity, and I would erase low vitamin D. Two things. And low vitamin D is easy. Everybody should be taking vitamin D. Like everybody. That's one of my mantras. Even the friends of my children hear me talk about vitamin D. Are you taking your vitamin D? Because without D, you can't absorb the calcium, and so you need D and calcium for strong bones. And you need weight-bearing exercises. It's also important that we focus on young people because it's building your peak bone mass that is critical. So, except for maybe our AV guy back there, most, probably all of us have reached our peak bone mass and we're on the decline. So peak bone mass comes in your 20s, okay? And so the more active you are, the more athletic you are, the better nutrition you have as a youth growing up into young adulthood and maybe up into your mid to late 20s, the better bank you have to draw from. Because then it's a race between bone loss and death as to whether you're going to have an osteoporosis-related fracture. So the more you've got in the bank, The more you can take out before you hit the fracture threshold. So, very important. Let's look at physical activity. First of all, the country, we have obesity epidemics, we have an epidemic of sedentary lifestyles. Everyone has become more sedentary. This is very, very unhealthy. We also know that women are not as physically active as men, and if you look on the right, you're going to see that for young women, for girls, 12 to 17, there's really no difference between white and Latina girls. But if you look at Hispanic, that's other. There is a difference. If you look, Caucasian women have the highest levels of physical activity compared to Latinas and African Americans. And the younger women are more active than older women. So this is a big opportunity for us to try and improve what we're doing in terms of health for women and public health in general. Now, interesting, because I'm very much in my own kind of personal journey, similar to what Dr. DeGioia mentioned, I've started to have a different perspective on how we need to address health and focusing on how do we engage patients to be active participants in their own health journey. So I thought this was an interesting study. Gender differences in motivation for physical activity. So these are all women who were 60 years or older, okay? And they were more likely than men to be motivated by, I'm going to look better if I exercise or I'm physically active. If I can spend time with others, that will motivate me to do exercise, meeting friends, losing weight. They want to do activities with the same sex and similar age group. Now, this may not be true for all women across all cohorts, all age cohorts, but for this age cohort, right, they want to have a class, an exercise class, with other women who look like them. That's an important concept as we get to how do we engage communities and community programs, right? Do people want to be with other people that look like them? Do they feel more comfortable doing those kinds of activities with their peers? And these women are less likely than men to prefer activities that are competitive, vigorous, and require skill and practice. So, this is the kind of stuff we should be thinking of as we're going to go out to try and engage women who are 60 plus to improve their level of physical activity. All right, now, the second O condition, osteoarthritis. Probably most of you are familiar with what osteoarthritis looks like on an x-ray, but just in case, I put it up there. So that's, a great looking knee on your left and a not good looking knee on your right, where the cartilage cushion, the joint space is now worn and the knee is very arthritic. There are clear sex/gender differences in osteoarthritis. So basically, across the lifespan, women have a higher burden of disease with osteoarthritis than men do. And you can also see that when we look at this when we look at knee osteoarthritis in particular, the prevalence for women is high. So that's the top line with the orange squares, okay? There's a huge delta compared to men. So I have a particular passion in this knee osteoarthritis space because years ago, we asked the question, why is it that women get so much more knee osteoarthritis than men? And I was part of a study group that was sponsored by the Society for Women's Health Research, and we had a multidisciplinary team. I was the tissue person. So I basically harvested bone chips and synovial fluid and synovial lining and then sent it to colleagues that did other research looking at vitamin D receptors, and we actually found that there are true sex differences in the tissues of osteoarthritic knees of men versus women. Now, there hasn't been any treatment that has developed targeting those differences, but it leads us to explore those lines of research because they could be very promising in terms of how can we impact the burden of disease for women. And weight is so important because being only 10 pounds overweight increases the force on the knee by 30 to 60 pounds with each step. So now we see this intersectionality of obesity and arthritis and lack of physical activity. So, how do we begin to address women's health through the lenses of gender, race, and ethnicity? First, I want us to take a step back and look at what contributes to our health. I found this, when I first discovered this, these concepts, I was honestly really surprised because only 11% of our health is related to actual medical care. Now, that may be a critical 11% if you're having, a stroke, or you're having a heart attack, or you're in a car accident and you fractured your femur, okay? But overall, that is still a relatively small percentage of what contributes to our health. Environment, 7%, social circumstances, 24%, okay? Those are modifiable to some extent. Genetics, we can't change who our parents are. But the biggest factor that contributes to our overall health is our individual behavior at 36%. And regardless of someone's social circumstances, regardless of their economic status, there's opportunity to improve health through adopting healthier lifestyles and improving our individual behavior. Now, that is also a hard thing to do, but there's opportunity. So, second, I want us to understand what we call the medical vicious cycle. All right, we'll start with joint pain. Joint pain leads to limited mobility, lack of physical activity. What happens? We keep eating the same, we gain weight. That weight, I just showed you, puts more pressure on the knee joint, exacerbates knee pain. So now this circle creates end-stage osteoarthritis. But that's not the only thing that happens with this cycle, because with lack of physical activity and obesity come the development of heart disease, hypertension, diabetes, and depression. So now these are the patients that will come into our clinics, seeing an orthopedic surgeon because they have knee pain and arthritis, and they have hypertension, diabetes, they're obese, and they're also depressed, which most orthopedic surgeons don't even want to think about, oh my goodness, should we even evaluate this patient for depression? Yes, we should. Do we? In general, no. Okay, so the key to breaking this vicious cycle is movement. Keeps our joints healthy, helps us keep our weight down, right? It's good for depression. It helps with glucose. It helps with everything. So the key is movement. Okay. Third, let's understand this green ring of social determinants of health. Anyone can get trapped in that medical vicious cycle. An affluent white male CEO can get trapped in it. And we've seen wealthy white men who don't look very healthy, right? They can get trapped. But it's more likely that women and individuals of color are going to get trapped in that vicious cycle because of this green ring of social determinants of health, right? They live in neighborhoods where it's not safe to walk. They live in neighborhoods where it's a food desert. In my privileged, sheltered life, okay, it wasn't until, maybe 10 years ago that I realized that my supermarket where I shop is the same supermarket chain in the poor neighborhood in Jacksonville, Florida, but the cost of apples differ in those two stores. What? How can that be? Why do I pay less for apples in my grocery store, and in the neighborhood where the poor individuals of color live, if they want to buy fresh apples, they pay more? It's just astonishing. Okay, so these are social determinants of health. Now, let's put around that the impact of public and private policy. These are very important issues. We've seen it with bundled surgical payments. So if we want to look at the way that we pay hospitals and physicians now with bundled payments around a surgical episode, so classically for a total hip or a total knee, right? The hospital and/or surgeon accepts financial risk in this model. So if I can save money, I'm going to financially benefit. And if I don't save money, I can get penalized. Oh, and I'll get a double whammy too, because not only will I get penalized in the bundle for a readmission, but Medicare is going to give me a second slap for my overall Medicare readmission rate and penalize me for that as well. So this leads to cherry picking of healthy patients and lemon dropping of unhealthy patients, right? And we have seen the biggest change in the practice of total hip and knee arthroplasty is post-hospital discharge. We don't send patients to skilled nursing facilities now like we used to. They go home. Now, home is always better if it's okay for the patient to go home and if they have enough support at home. And who's the patient that has support at home? The white affluent patient, okay? Who's the patient who, and I know this, and Tony knows, I mean, my 90-year-old mother broke her hip like 3 weeks ago. I got her down here to Presby, you know, I mean, I won't go into all the details, but last night I'm on a conference call with my siblings, and we are dividing up the schedule on who's going to be home to help mom. Each one of us has the ability to leave our jobs, work remote, and go basically function while we're there taking care of mom. We are privileged. So many families cannot do that, okay? And for families of low socioeconomic means, how can they take care of mom who just had a hip fracture or just had joint replacement surgery, right, when they're just out of the hospital? But now the surgeon doesn't want to send them to a skilled nursing facility because it's going to cost more money and disadvantage them in the bundle. All right, enough on the bundles. And now, this year, I had to put yet another ring around this, right? The pandemic ring. Who are the essential workers? Women are the essential workers. If you look across all of the essential worker categories, okay, strongly driven by women, strongly driven by people of color. Now, we have the high-level essential workers like doctors, nurses, physical therapists, healthcare providers. But once you get beyond that scope, right, we're talking about bus drivers, sanitation workers, etc. These are predominantly people from communities of color. And what we saw particularly early in the pandemic was the disparities just laid out bare for all to see when we looked at resources that hospitals had to provide care for those in their community and how disparate a lot of those resources were depending on the hospital. So the pandemic has obviously been terrible, but the one thing that I do believe it has done on a positive side is highlight the disparities that we have. Okay, now there are solutions. So I'm done with doom and gloom now. Let's talk about something positive. We can make a difference. We can do it better. We can embrace what I will call the biopsychosocial model of care, right? That starts with what matters to you. Dr. DeGioia and team are championing this approach as well, right? It shouldn't be about my knee pain. It should be, what am I missing in my life because I have knee pain? Maybe I want to run a 5K. Maybe I want to get on the floor and play with grandchildren. I'm not blessed enough yet to have grandchildren, but hopefully someday. But you know what I'm saying. The point is, it should be about what the patient, what matters to them and what they're missing in their life because of their condition, not the way we traditionally think of it. And then every goal for that patient is centered around Mr. Jones being able to get on the floor and play with his grandchildren, okay? So if we keep making the goal relevant and the progress to the goal relevant to what matters to the patient, they're going to be more engaged. Human-centered design, you're going to learn about that in the workshop tomorrow. Community input and engagement, and to leverage technology. So I'm going to briefly touch on some of these. I do feel that we have the opportunity to leverage the power of technology for what I'll call whole person care. In other words, supporting this biopsychosocial model. We are never going to be able to go back to not having technology, and we need to use technology to help us. So the way that I see this, and what we're doing with this new company that I've co-founded, is our company, it's called Vori Health, is basically focused on virtual musculoskeletal care. We have doctors, nurses, physical therapists. I'll show you a little bit about some of the tech that we're working on. And we see ourselves fitting into this larger ecosystem where primary care physician or anyone can refer the patient to us and let us focus on non-surgical care for that patient. All our patients have a health coach, right? Let us focus on that biopsychosocial model to try and improve that patient without significant intervention, without surgery. And you know what? Some people still need surgery. I'm an orthopedic surgeon, I know this, okay? Those patients need to be referred. They need to see Dr. DeGioia in person, okay? But not everybody needs to see the surgeon. And what happens when patients go from the primary care physician to the surgeon is what? They get surgery. Now, not everybody, but we know from peer-reviewed studies that spine surgery can be inappropriate in anywhere from 20 to 40% of patients, and hip and knee replacement inappropriate in 23% of patients. That's a lot of patients, okay? And it's not just that initial cost, it's the risk of complications, it's persistent pain, it's all those things. So the surgeons are not bad people, but just remember, when I've got a hammer, all the world's a nail, right? When I've got something I can do, I'll order the MRI, and anybody who's over 30, guess what? Your MRI isn't normal. There's something on it, okay? So I can see that. I mean, you will have a meniscal tear. Does that mean I should scope your knee? Probably not, but it gives me a reason to scope your knee. And then you want the quick fix. Why? Because we're not spending time educating you. We're not sharing with you, here's the negative of having part of your meniscus removed. It's going to accelerate the development of osteoarthritis in your knee. So there's so much opportunity for us, and we should leverage the power of technology to help us with this, and I'll give you a few more examples as we go along. So this just goes to our concept of the health ecosystem, seamless virtual and in-person care, data-driven, tech-enabled, evidence-based. So right now, Vori Health, we're focused on that center section, the integrated care, but the concept is build this great platform, engage patients, and then you can also move into both preventative care and also wellness and maintenance. Okay, now, this is just a little bit, I'll show you a couple fun slides that work that we're doing. So when we started looking at how we're going to build tele-rehabilitation, right? Tele-PT, basically. We went and said, what is the content out there? And it was all Caucasian. And we said, well, that's not so great, right? I mean, maybe people want to exercise to an avatar that looks like them. Maybe they don't, right? I joke with my team like, I want my avatar to be young Mel Gibson from The Year of Living Dangerously. Okay, now, the young people, you don't know that movie, but someday when you see it on, you'll turn it on and you'll remember my comment. Okay, for pediatric patients, maybe we get the rights to Buzz Lightyear, and they want to do their virtual exercises with Buzz Lightyear. This medicine and home exercises does not have to be boring. It doesn't have to be non-engaging. We can make it more fun. But we've never chosen to do that. But we need to do that because that's what will engage patients, which means then they're going to do it. I don't like the word non-compliant because that tells me that I have failed as a partner with that patient to engage them, to educate them to the point that they're actually participating and doing their home program.
Ready?
Okay.
Start.
Now, this is one of our engineers on the roof of his building, and this is demonstrating what we can do with sensorless motion tracking. So he got it almost right. Now he got it right. Oh, let's celebrate. Let's put some graffiti on the screen. okay? And we can
Seat
count.
opposed.
Yay, more celebration when you do it
Keep leg
right.
straight.
Okay? Why not, right? Why not make it more engaging?
Almost.
So, the point of this is that
Well
we
done.
can track and count how many exercises did he do? How many days, which days did he do them? Did he do them well? We can evolve to where we could have AI-driven algorithms that will allow patients to advance at their own level. Right now, when does the patient advance? When they go back to see their physical therapist for a face-to-face visit, and the therapist says, okay, you're doing well enough that we're going to give you some harder exercises. We're going to advance your home program now. Well, we should be able to do better than that. Or if the patient isn't progressing, then maybe we have to back off. Or if the patient hasn't engaged in the platform for 2 days, we can call them up and say, are you okay? Because we've noticed that you haven't been on. And the first question is not like, why aren't you doing your exercise program at home, right? The first question should be, are you okay? Because maybe something happened. So again, we can leverage the power of technology to engage patients and to do a better job of driving a care plan with them. Because if they do this, they will get better. Now, I also want to touch on technology to support shared decision making. And that, of course, is a focus on best clinical evidence in line with the patient's values and preferences. And that's the key, right? It has to be in line with their preferences. So at Movement is Life, we created a shared decision-making tool for knee pain. It allows 8 different treatment choices across the spectrum of options. It adjusts for gender, race, ethnicity, education level, and I'll go into this in more detail tomorrow in the workshop, but this is just a little intro. And the main thing is the tool is personalized so people can see themselves in the tool. So, for example, this is a patient whose knee pain today is 8. We look at pain, function, and impact on finances because of lost productivity. And the tool always defaults, one of the always options is do nothing. Why? Because most patients do nothing, okay? They don't do an exercise program. They don't do what Dr. DeGioia recommends that they do. And they come back a year later, and they're worse, and they haven't done those things. So we need to share with patients what happens if you do nothing. Now, the input that goes into this is based on age, gender, race, ethnicity, some comorbidities. And the output is based on cohorts like that. So a woman seeing this output knows this is what other women like me, okay, would be predicted to have. If I do nothing, my knee pain is just going to keep getting worse. Right? Now, if I lose weight, exercise, take some over-the-counter medications, and have an occasional injection, wow, look at the improvement in my knee pain. I can go from 8 to 3. So we call that the lifestyle modification option, right? Lose weight, become more physically active. And look at how well that knee pain stays down. Even at year 10, okay, the pain is 4 to 5 instead of 8. Now, the alternative, don't lose weight, don't increase your level of physical activity, but go see Dr. DeGioia and get your knee injected every 6 months and take prescription medication. That's the bottom one. And have knee replacement surgery at year 6, which is why at year 10, you see the pain has gone down to 1. So, trying to help people see what their future could look like, that is a future that is more aligned with their own personal traits, is more engaging. We did a pilot study with the tool, and basically the women that received the tool had self-reported levels of physical activity that increased by a statistically significant amount. We didn't have the money for Fitbits or more, what I would say, better quantitative data, but it was still helpful for us in our pilot phase. All right, last concept, emotional connection to others. Now, this is where technology helps, but it's not the only thing, right? Because if we're going to make behavior change, what we need to do is be able to connect to others. Sorry about that. Here we go. So one of the programs that we created at Movement is Life is called Operation Change. I'll talk about this tomorrow too, briefly. 18-week community-based course. We get 40 to 50. We've done it with women. You can do it with men. I mean, we just elected to start with women. We grouped the women based on race ethnicity. So we had African American cohort, Latinas, we had poor rural white women in Hazard, Kentucky. And if you want to talk about disparities, you need to go out into rural America, because we have bad disparities not just in urban America, but also in rural America. So 18-week program, 3 hours a week. First hour, education. Let's talk about diabetes or depression. Second hour, some kind of movement, as you see here. Third hour, motivational interviewing, small groups, right? What are the personal barriers to you making behavior change? Incredible results. 68% improvement in their sense of hopelessness, because these women are all depressed, okay? And this is without drugs or intervention, right? They're not seeing a psychotherapist. We're not giving them antidepressants. 18% improvement in their walking speed, okay? I mean, we had women tell us this program saved their lives. I was blown away. I thought it was going to be, well, it was the motivational interviewing. But that wasn't it. What they liked best about the program were the emotional connections they formed with the other women in the group, because that gave them the strength to make the behavior change. It was like one of these aha moments for me when I was like, duh, like we're doing it all wrong in medicine, okay? I can't be that emotional support for my patient. I got a whole bunch of patients, right? I mean, I can't do that. And maybe that woman doesn't have the emotional support in her family, because there could be all kinds of things happening in that family. But if we create communities for those women so that they can support each other, then we can get someplace. Still, we can also leverage the power of technology to create virtual communities. Now, in some of our low socioeconomic communities, they don't have a lot of access to internet, and that may not work. And they may not trust technology, and for all kinds of reasons. But it doesn't mean that we let go of the concept, because we take that same concept and say, can we make virtual social communities that will also help? And remember, this is what Alcoholics Anonymous does. This is what Weight Watchers does, right? They create emotional connections to help people make behavior change. So I'm going to close with this quote, which I really love. Illness can be transformed to wellness when we move from I to we. So thank you so much. Tony, what do you want to?
I'm going to do a couple of slides, weren't you?
Why don't I? Oh, wait
Yeah,
when you're done. Oh, wait when you're done.
Thank you, Mary. And a reminder, too, for those that are listening in, that you can start sending in your questions, because we have it set up that we can review questions as they come in. So please do that, and we'll take questions here as we move on. So again, just to sort of take the next steps and plant the seeds for tomorrow, as you've heard, there are lots of levels of problems that we have to deal with. Certainly the system of care delivery has resulted in uncoordinated and fragmented care, and as Mary mentioned, in many communities it's just non-existent. Secondly, the patient's needs are not always heard or factored into the treatment plans, particularly for bone and joint health, because it is uncoordinated and fragmented, and we have these disparities. So what are the opportunities for improvement that you can look at? Is first, we need to break down the silos in the current system, and that's by developing interdisciplinary programs that focus on the patient needs and bringing the services and the resources to the patient in the way they want to see it, rather than have to go see multiple different physicians or providers in the system, which is what happens now. You have to look at these gender-specific and cultural, socioeconomic aspects, or else you're not going to solve the problems. And there's certainly, Mary didn't talk much about it, but there's certainly disparities on the provider side, especially in musculoskeletal issues, especially in orthopedics, that we have to address. Because as Mary said, it just is important that we have in the community, patients talk to people that are like them, we're not going to solve all the problems unless on the provider side, we also have the same people that are the face of the person that they're taking care of. So about a year ago, and this actually came out of the pandemic, since we had some time, we developed this concept called Center for Bone and Joint Health at Magee as a pilot program. And I'll talk in more detail about how we developed this tomorrow. But this was a center that was attempting to bring together multiple subspecialties to focus on the patient's needs. It's all non-operative. We are part of the collaboration, the partnership, we meaning the Bone and Joint Center, which is the surgical side. But it was very much a collaborative effort. And we're in a great location at Magee-Womens Hospital because these services are here. And there's been a focus, obviously, on women's care for many, many years. So we thought it was the right time to be able to do that. The mission is co-design care programs, and co-design means with the patients. I'll talk tomorrow. There's a science that most people in healthcare are not aware of. It's called the experience-based design sciences, used in every other industry except for healthcare. And the number one rule is you always involve your end user in developing the systems of use, always. And you view everything through their eyes. So it is a science for those of us that are in a science and in healthcare. And it's proven. It actually, as an aside, was established by a professor at Carnegie Mellon, and he won the Nobel Prize for it, Dr. Herb Simon, if you're from Pittsburgh. He developed the experience-based design sciences in Pittsburgh and won the Nobel Prize for that science. So we have ties here in Pittsburgh with that. What it does allow you to do, though, is develop what we call personalized care as an approach to deliver care for everyone better, but also you can, in a scientific and a organized way, approach the disparities too, because you, again, are always looking and asking what's special, what do those patients need in those groups. So it is a personalized care approach, and although it sounds far-fetched sometimes that, how can I provide personalized care for the hundreds of patients you see in the office, it's possible to develop a system to allow you to get to that point. And it's certainly increased the proportion of women in orthopedics and particularly adult reconstruction surgery. Women, Mary, I think right now residence is maybe 15, 16% total. And adult reconstruction is less than 1%, which is what Mary and I are in as far as women participation. So again, there's a provider need that we have to focus on too. The tools for success and some simple ways to get started. Sometimes this can seem overwhelming to many of the groups we talk to, but there are real things that you can do right away. Go back on Monday and start doing. We'll give you some of those how-to tools tomorrow, but the three main ones is, as Mary talked about, what matters to you, we think is the best place to start in the co-design process, and to open up your eyes on what your patients need. And there's a methodology to this too. Co-design, which again is engaging the patients, the community as well in the design of care, and also the frontline staff. It's one of the things that we sort of forgot about, or maybe we didn't think about so much, but it's amazing how the frontline staff want to participate in the redesign of care and never really have an outlet to do that. And then lastly, team building. We focus a lot on team building because when you get to the implementation phase, that's always the biggest hurdle when you do these, these are disruptive kinds of approaches. To really implement it and to get traction, you have to engage your teams. And the teams are very different than the kinds of care teams that we talked about in the past. What matters to you, we're not going to take credit for what matters to you. It actually started in Boston. And I just blanked out on the name of but Maureen Bisignano, who was the CEO of IHI for many years, was the one that championed this tool. And we took it and sort of made it, operationalized it, made it useful. But it's asking open-ended questions about people's priorities. You don't ask, what's the matter with you? You ask what matters to you. And that's how you start the conversation. It's amazing how easy it is to do. And you get impactful information and you can get actionable information. And this is, if anyone wants to start, to me, this is the simplest and high impact way to start. And you could literally start Monday. And we have a whole bunch of stuff online and questions and surveys and things that we've used. Co-design, as I mentioned, is a science. Key thing, everything's viewed through the eyes of your end user. Team building It has to, if you're going to implement these changes, you have to build these teams. They're very unique because it cuts across your organization. It's not, it goes from the frontline staff all the way up to the VPs, and a different kind of coalition than you've had in the past. So we did this and we started this process as a pilot project. These are actually the partners right now at Magee that are participating in the Center for Bone and Joint Health. Midlife Health Center, Dr. Petragala is here, she'll talk tomorrow. They focus on perimenopausal and menopausal issues, and it was a perfect place for us to start because there's so much crossover between bone and joint health and what happens there. Our center, the Bone and Joint Center, now we're viewed as a surgical center, but the last time I looked, about 30% of our patients don't have surgery to start with. And as you know, arthritis particularly does advance, but you don't have to start with surgery. But so there are non-operative things, but Mary's very right in the sense, I think one of the most unsatisfying visits for patients in the past have been, you tell them they're not a candidate for surgery when they thought they were a candidate for surgery, and you don't give them anything else to do. It's completely unfulfilled on their part and on our part too, right? And the things that Mary talked about will prepare them for when it comes time for surgery if they go down that pathway. So it's very important to tie that in. Osteoporosis care, Magee, I didn't even know this before we started this, they have an osteoporosis care center, rightly, but I think the Midlife Health Center takes the lead in that. Bariatric and nutritional support, and this is non-operative bariatrics. We have on-site nutritionists at Magee, has become a very popular part of the program. Pain management, women and men perceive pain very differently, both before and after surgery. So that we bring those in, and it's all focused on complementary therapies, no pharmaceutical types. And then just recently, in the last few weeks, we have now an affiliation with Western Wellness Mental Health Services. It's the effort for Western Psych as an outreach into the community. It's all non-pharmaceutical, it's non-psychotherapy. It deals with issues with mental health, anxiety, depression, and coupled with what we're doing. So we're very happy to have them now as a partner. And certainly the Research Institute and Foundation who sponsors this, I'll talk tomorrow how they've been fantastic in helping us with the education process for patients, providers, and communities. And this is sort of the personalized care in action that we do. This is a program we actually did implement in the middle of the summer. It's a sort of a four-step process. First, they're referred to the program, and we have referrals from different sites, mostly our center and Dr. Petragala's center. Then we have a very short 10-minute screening call to gauge their interests and all. But then we have a 1-hour televisit in which there's an extensive discussion. It starts out with what matters to you. It talks about motivational interviewing and what's their goals. We also do screenings for mental health. We do physical screenings as well. We ask them, what would be the ideal program for you? We then take that information and we develop a personalized care program so they come on site then for a 1-hour visit that's coordinated with our providers, and then if they were interested in nutrition, they'll go to nutritionists. If they're interested in pain management, they could do pain management. If they have to come and see us, that's, it's there. It's exercise. I mean, it's all tied in there, but it's personalized based on what they need. The nice thing with this is, when we talk about personalized care, there are themes, right? I mean, there are sort of categories of interest that always become important, and the things that always have bubbled up is motion and activity, nutrition, pain, and managing pain, non-pharmaceutical management, and mental health issues have always bubbled up. So you can begin to make some generalities at the same time of having the personalized care program. So with that, I just, first of all, like to thank everyone here and remotely if you're listening in. And again, plant the seed. Hopefully at least got you interested in learning more about bone and joint health. But more importantly for tomorrow, it's really a how-to workshop. We'd really like to, we have a faculty, including Mary and myself and Alana, to understand what the problems are, but also take some of the tools we've developed and back to your own communities. So with that, we do have some time for question and answer period, and we have some questions there too. Why don't you take the podium, and then let me
We can share, Tony.
Yeah, well, so that they can hear me ask the questions.
I don't have an additional mic with our two mics.
Well, just come, we can share.
So first of all, whoops, sorry. Are there any questions from the audience you want to start? And if you use the mic, since it is remote, you have to have audio so they can hear. Denny? And introduce yourself, too, when you...
Hi, my name's Dennis English. I'm an obstetrician gynecologist, and this is an interest of me, primarily because I have an elderly mother, like yourself, who has some of these issues. More of a comment than a question. It was rewarding to see that you have identified the use of motion and activity in really improving life for many folks, particularly the depression issues. The interest I had this morning, I was taking a course on aging and cognition, and you may add this to your program, in that it turns out the thing that's most associated with improving cognition in the elderly is activity.
Absolutely.
And so I suspect if you look at the group of folks you've been working with as far as using motion to improve their bone health and depression, you'll find it also improves their cognition.
Absolutely. And a couple years ago, now I'm going to embarrass myself because I'm going to blank on the name. Researcher here from Pitt, University of Pittsburgh, doing research looking at cognition, physical activity, and race, ethnicity differences and disparities. So the connection between physical activity and brain health is, as you know, well established. Just like we're seeing this resurgence of the gut microbiome and brain health. Like all of a sudden now, you are what you eat. I think my mother taught me that like a long, long time ago. But now, with all this additional new research, it's really emphasizing like we have to pay more attention to that in order to be healthy. So it's all the things that we know we should do, right? We should sleep. We need to exercise. We need to eat right. We need to have social connections, people that we care about who care about us. If we did those things, we're probably going to be pretty healthy.
So there's a question online, which is a good one. It's about motivational interviewing. And this is something I was not aware of before we even started this program. And we learned it from Women's Life and Operation Change. So, Mary, maybe you can just explain what motivational interviewing is and why it's so important.
So, motivational interviewing is helping an individual understand what their personal barriers are to making a change. And then helping them work through how can they become motivated, right, to address those barriers. I'll share a story with you because I think it's really, it impacted me. So one of our women from our Operation Change Chicago program from the Latina group, we had a Latina cohort, we had an African American cohort. And that's another thing, when we first started this program and we were experimenting, we decided to group the women based on race ethnicity. And we had people say, well, is that really what you should do? Shouldn't you kind of be treating everybody the same? And we said, well, we don't really know exactly what we're doing. We're trying this and we're going to see what works and evolve it and refine it. And we've made some improvements to the program as we've learned. But that was one of the early decisions that we made that I think was very important because it allowed us to customize the program based on things that they were familiar with and enjoyed because of their cultural background. So what do I mean by that? So when we did an education session, right, and we did a food demonstration, there were food demonstrations were culturally appropriate, right? For the Latinas were different than the African Americans. So there was one woman in the Latina group, one of her barriers to change that this came up with the motivational interviewing was her husband and was very much against her bringing home these newfangled diet ideas, cooking ideas, right? And in that culture, of course, the husband's a very dominant figure. So she got the support to say, I'm going to keep cooking the meal like I usually cook for him. But I'm going to make one dish, one healthier dish for me, one little movement is life dish. Now, her husband made fun of her for doing that, but she did it. And she would eat her food and some of the other food, right? And then her children started to eat what she made, okay? And you know what happens next? Finally, the husband starts to eat what she makes. And so that's the power of one person, particularly a mother, to change the health and impact the health of all of those in her family. And that's how we make communities healthier. One parent at a time, one individual at a time, and that pebble in the pond ripple effect is what we need. So that motivational interviewing is, how do we help people understand? For her, it was the resistance of her husband, make the behavior change that's going to allow them to be healthier.
Maybe one last question before the break is, this is a sort of a higher level. Oh, Andrew, go ahead.
Hi there. This is kind of a follow-up. My name's Andrew Sparks, and I think this question came about when you were talking about reaching into the communities. With distrust in medicine, which is, pretty typical in these communities, whether it's racial communities or the rural communities that have a lack of trust, what are the ways that you break that barrier and kind of come down from the pillar that they often see medical professionals in?
So when we do Operation Change, the medical professionals are not there. Those are not the people who run the program. We go out and we find individuals in the community, and then we train members of the community who are interested in being the motivational interview leaders, okay? So it really has to be based in the community. We don't give talks about knee replacement surgery or talk about those things, right? It's really focused on, is there medical education that occurs? Yes, there is. And we will bring people in to talk about those medical issues, but the focus is not, we're a bunch of, we know it all, I know it all, I'm the doctor, right? And I'm gonna come in and educate you. It is really a focus on, what do they need? How can we help? How can they empower themselves? That's the key. Otherwise, they'll never embrace change, because first of all, they oftentimes have a high level of distrust for, as we've seen with resistance to the vaccine, right? A high level of mistrust with the medical community. So it can't come across that way. It will fail immediately.
Thank you.
Well, with that, I'd like to close the session today, but I hope that we've generated enough interest. If you would like to attend the workshop tomorrow, it's from 10 to 12. And like I said, it really is we've tried to arrange it as a how-to to give you some tools to actually implement some of the programs that we talked about today. And again, I'd like to thank Mary very much again for coming back to Pittsburgh. And we hope to see everyone tomorrow. Thank you.